So this video intend to answer all the questions that I've asked in the group earlier. So let's begin with the cycle of the women life. So it starts with the puberty. So puberty is a capability of the sexual reproductions of a woman. So it's begin with the, you can memorize these mnemonics. It's in the MCQ: Talaki, Adrenaki, and Manaki. Talaki, it's a development of the breast. You can remember teat. So the breast development can be classified into the tenor staging, 1 to 5 tenor. Okay, so if the talaki occur before 8-year-old, then you can classify those as a precocious puberty, and followed by the adrenarche with the formations of the pubic hair and also the armpit hair, and also followed by the menarche. Menarche, the mean age in UK is about 14-year-old. If it occur before 10 years old, then you classify those as a precocious puberty as well. And the absence of the menses up to the age of 16 years old need to be investigated for the primary amenorrhea. So this is the reproductive age, which will be talked later. And at the 40-year-old, if the menses ceased before 40 years old, then you can classify those as a premature menopause. And the mean age for menopause in UK is about 45-year-old. So anything happening in between can be think of perimenopausal, like irregular menses, or climacteric symptoms. And for Malaysia, for example, we have the mean age of menopause at 51-year-old. So it's different from countries. All right, so let's talk about the reproductive age. So what happened is that the menses. So what happened at the beginning is that the GnRH will start to have the pulsatility patterns of the GnRH secretions from the hypothalamus. The GnRH will start the pulsatility and cause the release of the LH and FSH from the anterior pituitary. So from the MCQ, they ask about how the pulsatility pattern. So it's every 90 minutes. So as you know, the HPO axis, we have the hypothalamus, which secretes the GnRH, which will stimulate the anterior pituitary to produce LH and FSH. So LH, FSH is secreted, and FSH will stimulate the granulosa cells of the follicles, and the LH will stimulate the theca cells. Okay, so let's go back to this folliculogenesis. So in here, we have two phase, which is the follicular phase and also the luteal phase. So let's begin with the follicular phase. So it starts with the primordial follicles, whereby in MCQ as well, because women is very special, in utero we have, as a fetus, we have about 7 million of primordial follicles as a fetus in utero, and at birth it degenerates and only left about 2 million. And during puberty, it's further degenerate and only left about 500,000. And the follicles that had ovulation is only about 500. So how to rationalize this number? Just calculate, like, for example, the menopause at 45-year-old and menarche at 14. So multiply by 12, and each month you're gonna have about 2 to 3 follicles that's gonna mature. So we're gonna get about 700. So this is how we get the 500s. It's a range lah. All right, so from the primordial follicles, it will differentiate into the primary follicle, which actually the change of the granulosa cells from the flat cells to the cuboidal cells. And during this, it's less sensitive to FSH at this point, FSH from the pituitary. And it's further differentiate itself into the secondary follicles. Secondary follicles, basically just the granulosa cells, had a mitotic activity and appears to have 9 layers of granulosa and differentiate itself into theca. And theca can have interna and also externa. And theca and granulosa have different sort of kind of behavior, because LH will stimulate the theca cells to produce androgens, which you see LH is high in the patients with PCOS because and you see this the symptoms of the hyperandrogenism, and the androgens will stimulate granular cells to produce estradiol. So androgens, specifically androstenedione, will convert it into estradiol by aromatase enzyme. So here is where our letrozole comes into play, which is the aromatase inhibitor. And at the same time, the granular cells will produce inhibin that will inhibit gives the negative feedback to the pituitary and inhibit the FSH secretions, which also tells us why the menopause women will have high FSH because of the granular cells already absent, because the potentials of the ovarian reserve already reduced. So the granular cells is not there. So FSH, the pituitary tried to stimulate the granular cell which is not present, cause the FSH to be high. And if it's more than 30, then you can consider that as a menopause. And after that, what would happen is that there will be the granular cells will produce estradiol. So estrogen at this point will increase. So the increase of the estrogens will further stimulate the folliculogenesis, and there will be a pre-antral follicle or antral follicle. Antral follicle basically a oocyte with the fluid-filled cavity, and as you can do a follicular tracking at this point, and you can see the size. And antral follicle basically, and also AMH, is one of the methods to see the ovarian reserve, because AMH is produced by the granular cells. So the antral follicles will further mature, and you can see a dominant follicle with very huge fluid-filled cavity, and it will just like it will engulf the ovum. So here you can see that the things that engulf the ovum is actually the granular cells. So this is where the questions about the structure of the ovum, which is nucleolus, nucleus, cytoplasm, membrane, zona pellucida, and also the corona radiata. This is also to know the label is also one of the MCQs in past MRCA, which is this important because for us to understand what happened during the IVF, when the sperm wants to penetrate the ovum, it needs to release the acrosome reactions by releasing the hyaluronidase enzyme to disperse into the corona radiata and penetrate the zona pellucida and get into the ovum to see the nucleus. And okay, so what happened after this is that release of the ovum. So release of the ovum is basically an actions of the luteal hormones, which cause the contractility of the follicles and release of the ovum. So it will left the corpus luteum. The corpus luteum will produce the progesterone or 17-hydroxyprogesterone, which the reason why we give the progesterone as a luteal support, especially after the IUI or IVF procedures, right? Okay, so let's draw this menstrual cycle, 28 days. Okay, what happened is the follicle stage, follicular phase, and this is what happened in the endometrium. So at the beginning, the FSH will be not that high because of the inhibin here, and the estrogen slowly increase because the granulosa cells producing the estradiol, and when it peaks, it will stimulate the surge of the LH and also the FSH. So this LH, this is FSH. So that is why when we take a baseline investigations for subfertility, infertility case, we'll see the LH and FSH value is 1-to-1 ratio in the normal conditions. In PCOS, usually the LH will be higher, and if it's a menopause, then FSH will be higher. So the surge of the LH causes the contractility of the follicles, and this usually the question that being asked: how many hours before the ovulations the LH surge occur? So the answer is 24 to 36 hours. It is something that you have to remember, because we're gonna confuse with the Pregnil that we always give for the IUI, for example. Sometimes we give up 36 up to 40 hours. The injection of the HCG, which after that we proceed with the IUI procedures or IVF. So have you ever thought, why do we use HSG instead of LH? This is because the HCG structure is similarly to LH, FSH, and also TSH. So this is also one of the MCQs. So after that, ovulations occur, and the LH will reduce again with the FSH, and the GnRH. And at the same time, because of the granulosa cells producing the estrogens, so it has a peak here, and after the release of the ovum, corpus luteum also produce the estrogen and progesterones, but mainly the progesterone. So you can see the progesterone initially was low, and subsequently it peaks on the day 21. The reasons why we take the day 21 progesterone to see the ovulations. So if it's less than 35, then you can say the women is an ovulatory cycles. So this is the progesterone. By understanding this, basically you can actually understand how to stimulate and how to inhibit the menses. For example, if a woman plan for a pilgrimage, or you want to inhibit the menses because of the menorrhagia, for example, you want to stop the menses so that you can optimize the HB. So you give a continuous POP rate. So basically you want to maintain this luteal phase. The luteal phase. So you want to maintain the progesterone level so that you don't have the bleeding. But if, for example, you want to stimulate the menses, you give like 5 days of the progesterone, and you stop the medication, and few days after that the patient will have the withdrawal bleeds and start the cycle again. And the same thing, if you want to give COCP for pilgrimage, you don't have to start like 3 months. You can always try to start somewhere here, so that you can give the continuous COCP to prevent the menses. So I hope, another thing about the estradiol. So there's also in the MCQs that talk about the types of the estrogens. So we have estrogen earlier during the puberty age, before the puberty, and then during the reproductive age we have the estradiol, and then again during a menopause, estrone is the most the primary estrogens. And during pregnancy, the main estrogen is estriol or E3. Estriol is the type of estrogen that produced by the placenta to support the pregnancy, and the placenta is producing basically 16-hydroxy DHEA, and it will secrete 16-hydroxy DHEA and produce the estriols. the reason why we have a different kind of estrogens. Okay, thank you.